have the slides with us, so we will only be sharing the slides, sir.
Okay.
Thank you so
Thank
much,
you.
sir.
You're reading history?
No, you don't want to read.
It is on the screen. I'll just say a few words. I mean, we all know. Professor Dinesh Makhanlal Bugra CBE single-handedly elevated the stock of Indian psychiatrists on the world stage. I think that's some of the whole his contribution to psychiatry on world stage and particularly Indian psychiatry. He headed the Royal College of Psychiatrists, World Psychiatric Association, and recently the British Medical Association, a rare honor for a psychiatrist. He is emeritus professor at King's College London. Social and cultural psychiatry is his forte and his passion. His Uber consists of, I think, 50-odd books and hundreds of book chapters, and I think nearly 1,000 or even more scientific papers. We are indeed very fortunate to have him with us today for the first time in the Association of Industrial Psychiatry Conference. Thank you very much, sir, for taking so much time to be with us today. May I now request Professor Bugra to deliver his lecture.
Thank you very much, Brigadier Raju and Brigadier Saldana for organizing it. And thank you very much for inviting me and for your very kind introduction. Can I have the first slide, please? I'm going to be talking about issues related to mental health in the times of COVID-19, particularly the UK experience. One note of caution that the data is changing on a daily basis. So what I prepared, and by the time it goes out, things may well have changed. But having said that, the main message really is that certain communities have suffered disproportionately higher rates of COVID and also higher rates of mortality. And there are a number of reasons, and I hope to cover some of that. Next slide, please. So we know it kind of started from Wuhan. We don't know the exact circumstances. The WHO delegation has come back, but they're in the middle of writing their report, so we don't know what happened. But what's generally agreed that this virus did not escape from a lab, but was transferred in a wet market in Wuhan from bats to human beings, and then it suddenly spread. And in a globalized, interconnected world, it was inevitable that this was going to turn into a pandemic. And although we have made a lot of progress in terms of vaccination and controlling the virus, I think we're still in the middle of pandemic. My guess, and its best guess, is that it'll probably go on for another 18 months, 2 years before we're completely out of it. This is, just to remind ourselves, SARS-2, called coronavirus disease 19, so COVID-19 for short. Next, please. And there are three specific issues related to coronavirus and mental health. I mean, firstly, its impact on general population. And there are a number of reasons why we ought to be considering that. Firstly, it is about trying to deal with people in social isolation, people in lockdown, people who cannot visit their families. And there have been incredible number of stories and people who have died alone, and their family members were not allowed to attend their funeral, to say goodbye, etc. The second point really is about impact on people who already have pre-existing psychiatric disorders and what's it going to do. And lastly is the mental health of patients who have COVID and those who have recovered. And there's increasing evidence that people who've spent a long time on ventilators in intensive care units are beginning to show signs of post-traumatic stress disorder. Next, please. And we wrote about the kind of 5 stages, like the stages of grief. There were 5 stages in response to the pandemic. Firstly, it was fear, which lasted for a few months, and then it turned into anxiety and panic. And when people started bulk buying food, tins, toilet paper for some reason, etc. And then there is a sort of sense of anger that, our so-called leaders should have warned us, should have looked after us, should have done A, B, and C. And that kind of led to a sense of depression. And if it was, that anger, if it was introjected, became depression, particularly related to the fact that people felt trapped. And it led to a lot of violence if it was externalized. And we've seen instances in America, particularly against the whole idea of wearing masks. And finally, there's a degree of acceptance, and you try and deal with it the best you can. Next, please. And next slide, please. One of the things that we have to bear in mind is that quite often when epidemics or pandemics occur, we tend to forget their impact on mental health of people. So generally, we know that from Ebola, from SARS-1, from Middle Eastern respiratory syndrome, etc., there are high levels of anxiety, high levels of alcohol and substance misuse, and then the sequelae thereof, and people who survive feel guilty, people who have lost somebody feel the grief and the frustration and the anger. Next, please. So in societal responses, certainly again, I'm talking very much about the UK experience. There is a sort of first stage of lockdown, and then gradual opening of public places and schools, and then eventually cinemas, theaters, stadia, and others. And what's become very clear is that there have been a number of mistakes made in the UK. We are now into our 4th lockdown. But if you go out for a walk or your physical exercise, you find that traffic is still pretty heavy, and people have just either got used to it, or partly because of vaccine, they feel that they are safe and they can carry on going back to what was normal. Next, please. So there's been a lot of discussion, and certainly in this country, about social distancing. And I find the term rather difficult to accept, because this is about personal distancing, it's about physical distancing, but at the same time, we need social closeness with people who we cannot see face to face. So through Zoom and through other means, we should be able to connect with each other. And terms do matter. I mean, I think the problem is that just social distancing has caused a degree of untouchability, that if sometimes you see people coming towards you on the pavement, you walk into the road, or they walk away from you, or, so it just gives a very strange message. And certainly there have been major lessons to be learned from the UK, from Brazil, from USA, that response to the pandemic has been very disjointed and practiced. And we've seen the number of excess deaths in the UK, in Brazil, and in the US and other countries. So the challenge really is, who makes these decisions? Are scientists, virologists making those decisions, or politicians are? Next, please. So it can lead to isolation, self-isolation, loneliness, and we are working from home. So endless meetings on Zoom. So there's a kind of Zoom fatigue, because you can't sort of stop and have a cup of coffee or talk to somebody in the corridor and share ideas or do things. Next, please. And quite often during the day, you have a lack of structure. You keep getting distracted. The doorbell goes because you're expecting a parcel. something comes along, and there is a limited social contact, as I said earlier. Next, please. And since January last year, there have been thousands of studies, and one of the challenges is that for a small journal like International Journal of Social Psychiatry, which I edit, on average, we used to get about 300 papers a year, so one a day. And in the last year, we've had about 1,200. Vast majority are COVID related, vast majority are online surveys, and vast majority are Me Too kind of papers. Somebody's done something in Turkey, so let's do that. Somebody's done something in India, so let's do the same thing in Thailand. So the quality of papers and research is quite variable, and they're using various research tools. And there's overdiagnosis of anxiety, depression, and other conditions, which then get turned into psychiatric diagnosis, although these are normal human reactions. Next, please. So I'm going to talk about the vulnerable, underprivileged populations in the UK, which include women, children, elderly, minority racial groups, ethnic minority, LGBT populations, poor populations. And we need to bear in mind that there is a challenge in definitions and heterogeneity of groups, and we need to focus on race, gender, and poverty, certainly in this country. And perhaps if we have time, we can have a discussion about it. Next, please. So we also know there's considerable research evidence that Black, Asian, minority ethnic groups in the UK have higher rates of diabetes, hypertension, obesity, other physical illnesses, osteoarthritis, arthritis, chronic obstructive pulmonary disease, etc., and their impact on mental health. Next, please. And in addition, there has been the challenge of institutional or structural racism. And in the first lockdown, there was very clear evidence that if Blacks were going out to do shopping or in their cars, they were much more likely to be stopped. Black staff are less likely to be listened to if you whistle blow in the hospital. And a lot of East Europeans, minority ethnic groups are on frontline care home, low-paid situations, and they had problems in accessing personal protective equipment. Next, please. So as I said, the data keeps changing, but these are the kind of findings in October, and to a degree, these have stayed reasonably stable, or there may be a minor variation. Asians were 1.5 times more likely to die in comparison with white English. Black Africans were 2.7. Black female Caribbean origin were twice as likely, and other non-whites were 1.3 times. Next, please. So again, when you look at the Asians, and this is a consistent finding, it's still the case that Bangladeshis are much more likely, that almost 3 times, and it's now dropped to about 2.6 times, followed by Pakistanis, followed by Indians. And there is evidence that both these groups have high rates of metabolic, cardiovascular, and respiratory illnesses. Next, please. And Chinese have the lowest rates. And, again, if you had a positive test, risk of dying is twice higher for Bangladeshi group and nearly 1.5 times for Pakistani and Chinese. Next, please. Indians are marginally higher, as are other Asians. But again, it is quite sort of interesting that part of the challenge for all of these comparisons is how we define each groups. And I just want you to bear that in mind. Next, please. And we know that if you have diabetes type 1 and your HbA1c is equal to 58 millimoles or less than that, you're twice as likely if it goes above 58. You're 2.7 times likely if it's unknown. You're 3.3 times likely to die of COVID. And similarly, in diabetes type 2, between 1.5 and 2.3 times. Next, please. And we know that it's not a UK problem. In the USA, there's been very clear evidence that mortality due to COVID-19 was much higher in non-Hispanic Black individuals. And again, this was partly due to that they are in, driving buses, driving underground trains, frontline healthcare, preparing food, serving, cleaning, maintenance. And they're almost twice as likely to be doing these low-paid jobs. Next, please. And in the USA, Asians were less likely. And again, one of the problems is that in the USA, Asians includes East Asians rather than South Asians. So that's something that we need to bear in mind. And again, disproportionately high death rates in Wisconsin, Kansas, Michigan, Missouri, and Illinois. Next, please. And this concept of COVID age, which has been developed in the UK and has been used quite widely, that it summarizes vulnerability for combinations of risk factors, which include age, ethnicity, sex, and various health problems. So you translate the risk associated with each risk factor. Next, please. And what it means is that if it's a healthy white woman, age 40, her COVID age is 40 minus 5, so 35 years. So she's kind of healthier. A white man aged 45 with BMI of 36 with severe asthma has a COVID age of 45 plus 13 due to his BMI plus 11 due to his severe asthma. So his COVID age is 69. So kind of 24 years added. An Asian woman aged 50 with type 2 diabetes, unknown HbA1c, has a COVID age of 50 plus 5 plus 5 plus 20, so 70 years. So, being a woman, she's kind of takes out, goes down to 45, but then, diabetes and other things kind of add to her year. Next, please. So it's based on the vulnerability of healthy white men. So it's, if COVID age is 25, then that's equivalent of healthy white man age 25 with a COVID age of 55 is the same kind of vulnerability as a healthy white man. Next, please. And added years of age due to BMI. I mean, if your BMI is between 30 and 34.9, you have 4 years added. If it is between 35 and 39.9, 5 years. And if it's over 40, 10 years get added to your age. Next, please. And similarly, there's a kind of, as I said, for diabetes type 1 between 8 and 13, type 2 between 4 and 9. And there is a moderately robust evidence that that is the case, that we're not just kind of making these figures up. Next, please. So similarly, it's kind of heart failure, cerebrovascular disease, chronic respiratory disease, kidneys, if you've had organ transplant or liver disease, you're sort of much more likely. And for respiratory disease and kidney disease, there's moderately robust evidence. And for the rest, it's kind of provisional. Next, please. And risk of dying following testing positive, and that's kind of still relatively stable. The 70 times higher in people 80 or over, higher in males, higher in those living in deprived areas, higher in many Black, Asian, minority ethnic groups, even when you adjust it for age, sex, deprivation, region, and ethnicity. So there is a clear differential. Next, please. So ethnicity and income inequality are independently associated, and we know that social determinants of mental health, if you are poor, unemployed, living in overcrowded settings, you don't have access to green spaces, you're much more likely to have psychiatric disorders. So this is a kind of double whammy. They're also much more likely to use public transport to travel to work and work in occupations which places them at increased exposure to COVID. Next, please. So it's what's very clear is that in this qualitative survey with about 4,000 subjects, when the Public Health England did, this is available on their website, did a qualitative survey that Black, Asian, minority ethnic groups compared to their white counterparts, expressed deep dismay, anger, sense of loss, and fear. Many had lost colleagues, friends, family members, and had sort of fairly severe social, physical, and mental health impacts and complications. Next, please. So what the sort of argument has been that this partly about structural and societal environments and socioeconomic factors, increased risk of exposure, increased risk of complications, and higher rates of pre-existing long-term conditions, mental ill health, poorer uptake of prevention services, and other risk factors. And what's been shown quite clearly is that certainly Black, Asian, minority ethnic groups also have their health behaviors are quite problematic in that they're more likely to be smokers, more likely to do less exercise, more likely to drink more, etc. Next, please. So, and we know that, from the survey and from studies before that the economic disadvantages leads to poorer health outcomes associated with smoking, obesity, hypertension, increased risk of infections, and obviously issues related to lack of trust, racism, and clear public health messaging. Next, please. So similarly, there is clear evidence. About 18 million people in the USA, 8 studies from the UK showing that relative rates for Blacks are almost twice, for Asians 1.5 times. Next, please. So let's move on to the next, please. There's higher risk of intensive care admissions, increased risk of infections, and subsequent death, as I mentioned earlier. Next, please. So, as I said, there's also there's the kind of infectious diseases, differences in lifestyle, diet, etc. But also, some communities are much more likely to use complementary medicines. And you may recall that the health minister of Sri Lanka was taking some medication which had been, some Swamiji saw it in a dream and gave her the medication. And in spite of that, she caught the infection. So that's not an unknown phenomenon in minority ethnic groups, because partly it's the familiarity and access. Next, please. So gender is less vulnerable to the virus, but there is a kind of potential shadow epidemic of sexual physical violence perpetrated by intimate partner in the previous 12 months. And this is largely due to confined living conditions. Next, please. So it's been a surge globally. In France, it's increased by 30%, in Argentina by 25%, in Cyprus, 30%, Singapore, 33%. So this consistent across countries. So it's not because it's a poor country or a small country. So that increased violence against women due to lockdown and the secondary impact of COVID. Next, please. And next slide, please. We've got stuck. Can we have the next slide, please?
So we're having a minor glitch. We're just working on it. We'll be back.
Okay.
2 to 3 seconds, sir.
I will carry on. I've got only about sort of less than 10 minutes to go.
Sure, sir. Sure, sir. We'll just catch on soon, sir.
So I think similar figures have emerged about sort of child abuse and violence against children because you're cooped up, and particularly when schools are closed. And we have considerable evidence from other studies that there is issues related to adverse childhood experiences. And if you've had more than 4 ACEs in childhood, you're much more likely to develop psychiatric disorders in adulthood. And what that has meant is that we need to be careful about the long-term effects of lockdown and children not going to school, not being able to socialize, and what that would mean. The other additional problem, of course, is gender and economy, that quite often women are in low-paid daily wage jobs, particularly in low-income countries. And we know from Liberia, where 85% of daily market traders are women, Ebola caused a lot of problems for women's livelihood, their economic security, and therefore that's another factor in them getting faced with violence, interpersonal domestic violence at home. Next, please. Similar findings have been reported after the Zika outbreak in Latin America. And again, women's economic security and the impact lasted much longer. So this is going to be quite a major challenge for the world economy to look at how do we stop people from falling into extreme poverty and contributing to their mental ill health. Next, please. Are we stuck again?
Yes, some glitch is happening.
Okay.
We're really, really sorry for the inconvenience.
So I think what we need to be remembering is that the vulnerable groups like women and children are much more at risk of violence, abuse, be it sexual, emotional, or physical abuse. And in many settings, we would need to be careful about, there is certainly a point about vaccine hesitancy, and Black, Asian, minority ethnic groups are showing much lower rates of acceptance of vaccine in this country. And I don't know what it's like in India, but from what I hear, the access to vaccine and the rollout has been relatively positive, and the acceptance has been much greater than it has been in the UK. So that raises a certain number of challenges for us in terms of mental health. So as I said it right at the beginning, that there are 3 things. I mean, mental health of the general population, what do we do about that? And so the advice and the impact really is that we need to make sure that we look after our own mental health and of those who are around us. But secondly, it is about giving very clear messages, particularly in terms of economy, in terms of earnings, and in terms of reducing the abuse. There's also a related issue, which is about people who are in psychiatric institutions. Quite often they are in cramped wards, more likely to infect each other, infect the staff, or the staff coming from outside are more likely to spread the virus. So what do we do? And again, I think there are big challenges for all of us as professionals that we need to be tackling that. And lastly, the challenge of survivor guilt and pathologizing normal human responses or medicalizing them. We need to be thinking very carefully what are the steps that we need to take to make sure that there are no that just when the services are under pressure, that we don't sort of increase people's expectations by medicalizing issues and then adding further to the pressure of frontline workers and mental health professionals. So I think I've got sort of 3 minutes to go, so I'm going to stop there and take any questions or comments. So thanks once again for inviting me, and thanks for listening. And I'm sure the slides can go on the your portal and people can access those. And if there are any queries, feel free to email me or get in touch. So thanks very much and have the rest of a wonderful day.
Before I hand over to Brigadier Saldana, that is a veritable tour de force, sir. I thought you will speak only in UK, but you have covered the entire world about this aspect. One question that crops in my mind is, apart from other various aspects you have covered, wide range of topics, what will be the effect of corona on the birth rate?
Yes, slides nikal
I think do we have any figure? I mean, probably it's too early to have such figures.
I think there was a news report last week or the week before that the rates are going up, certainly in the UK. And I don't know whether that's a kind of universal thing or not. So we'll have to wait, for a period of time to see whether that's kind of valid or not.
Wonderful. So from my side, sir, thank you for responding a very short notice. Very kind of you. Over to Brigadier Saldana to his comments and summing up the session.
I think Professor Dinesh Bugra has left little for me to sum up. I think he has covered each and every comment of COVID and BME. I thank Professor Bugra for accepting our invitation in a short time and giving us the British perspective on COVID. We have been hearing. I don't know. But still, as the newspaper say, the British are under lockdown time and again. In India, people are roaming around freely as though there is nothing. You see, that is a difference. Yeah. So everything has come to a normal life here, except for the restriction imposed on the curfew from night 11 o'clock to morning 6. It means nothing.
But it kind of stops me from traveling to India, you see.
Oh, yes.
The only difference is here in Pune, the police catch you and fine. I went to Patna recently. I mean, if we are on a different planet, there is nothing like COVID anywhere. Everything going normal.
All right. And what about...
I find there are no questions. In fact, there is no questions in the chat box. I was eagerly looking forward to. Anyway, very nice seeing you live.
And you
hearing you also speak.
Kalpana is on the call as well.
Yes.
Yes, sir. Good afternoon. I heard your lecture completely. It was very nice to see you.
I wasn't
except for the small minor glitches because the Wi-Fi was going in between off and on.
All right.
So
okay.
That was a problem. So we could not. Anyway. Thank you so much, sir. Once again.
Thanks.
Thank you very much.
So we'll
May the
see you another time.
And keep you safe, healthy.
And you all too. Look after yourselves.
Thank you, Brigadier Raju, sir. And over to our MC, Dr. Tahura Ali.
Thank you so much. We are extremely grateful to our respected chairpersons and speakers for this very enlightening session. We will now proceed to disperse for lunch to once again assemble at 2 p.m. Thank you very much.
Lunch is virtual.
We will join you at 2 o'clock sharp. We will begin with 2 o'clock sharp for the award papers. Thank you so much. Till then, have a good lunch.
It's due, sir.